Okay, so this is part 2 of our CP Chapter 6 about oxygen and or gas transport. So in this section, I just wanted to start off talking about shunting. This is where I kind of broke off from part 1, just because I feel like there's a little bit to understand about shunting. It's a good stopping point. So shunting refers to the portion of cardiac output that moves from the right side of the heart. So it moves from the right side of the heart to the left side of the heart without coming in contact with oxygen. Okay. So there's two types of shunts that can occur. There are absolute shunts or true shunts, and then there are relative shunts or shunt-like effects. Oops. So absolute shunts are made up of your anatomic shunts, so this that normal 3% that come from your bronchial venous drainage that we talked about before and your thespian veins. Okay. It can also come from things like congenital heart disease. So sometimes babies are born, this is their heart, this is your aorta. Okay. Break it into its chambers. Ooh, that's bad. So there's sometimes that a baby, think about it. This is unoxygenated blood over here. And then this is supposed to be oxygenated blood here that goes out into the aorta. Okay. So in babies, sometimes they have congenital heart diseases that there's like a hole here. Oopsies. There's a hole here. So then that causes some of this oxygenated blood or unoxygenated blood to go into the left side of the heart directly and get pumped out, reducing the overall percentage of oxygen saturation. You could have interpulmonary fistulas, so that's kind of holes in that um, pulmonary blood flow, so that you don't get, the blood's going to the lungs. Oh my lordy. The blood goes to the lungs, but here it doesn't come into contact with oxygen. So then when it goes back to the heart, it's less oxygenated to the heart. Mm. Then you can have vascular lung tumors. So actually, a lot of times lung tumors become very vascular, which means that the tumor has a lot of blood vessels going through it. That's why lung cancer patients have a lot of bleeding issues. So because of those vascularized tumors, a lot of times the blood flow goes through the tumor, isn't going to the alveoli to get oxygenated, and then goes back to the heart unoxygenated. You can also have some capillary shunts. This is caused by either atelectasis, fluid accumulation in the alveoli, or alveolar consolidation. So, these patients, kind of the sum of those anatomical shunts and those capillary shunts, are referred to as those true or absolute shunts. It's important for you to understand that you can give these types of patients as much oxygen as you want to, but they typically tend to poorly respond to O2 therapy because it's not for lack of oxygen in the alveoli. It's because the alveoli is full, so it can't accept oxygen, or the blood's not going to those oxygenated alveoli. So that absolute shunting is also referred to as refractory hypoxemia. Okay. And Typically, like I said, it's not going to respond to oxygen because the alveoli aren't able to accommodate any type of ventilation. That blood bypasses the functioning alveoli. So typically what we do to fix this is we apply positive pressure to open up these alveoli or these consolidations to improve oxygenation. Relative shunts are when pulmonary capillary perfusion exceeds alveolar perfusion. So, or when pulmonary capillary perfusion exceeds alveolar ventilation. So I'm getting blood there, but my alveoli don't have oxygen, or enough oxygen. So some common causes of this would be hypoventilation. So I'm not breathing deep enough or fast enough. It can happen because of ventilation perfusion mismatches. So the amount of ventilation is decreased, my perfusion is increased, so I have that mismatch happening. I can have diffusion defects, so the oxygen gets into that alveoli, but it doesn't diffuse across that AC membrane because of, thickening of that AC membrane or decreased surface area of that AC membrane. So typically with relative shunts, you can increase the FiO2 and see an improvement in oxygenation. So for relative shunts or shunt-like effects, I can give the patient additional oxygen and I should see an improvement in their saturations. So I thought this was a good picture from your book just to kind of demonstrate this. So your normal alveolar capillary unit, you get your blood flow through, ventilated alveoli. It's unoxygenated. As it passes that alveoli, it becomes oxygenated blood. So anatomic shunts happen where some of the blood goes through and gets oxygenated, but then some of the blood never comes in contact with these ventilated alveoli. So it remains unoxygenated and it's going to mix with that oxygenated blood and decrease that oxygen saturation. Okay, so that's an anatomical shunt. You can have those capillary shunts where you have a collapsed alveoli and there's no O2 got in here, or if it came filled with fluid, so no O2 can be accepted into that alveoli, so the blood passing over these alveoli won't come into contact with oxygen and it'll stay unoxygenated. And then here's your shunt-like effect. So if you have alveoli with decreased ventilation, so not a lot of oxygen's getting in here, then it can't get into the blood. Or if I have this thickening of the alveoli wall, which is causing a diffusion defect, then diffusion is slowed down, can't go into the bloodstream, and I have lower oxygen concentrations in my blood. So I thought that was a good picture. So that end result of any type of shunting is going to be considered a venous admixture. So this is that mixing of non-reoxygenated blood with reoxygenated blood after it comes in contact with that alveoli, so downstream of your lungs. And that just overall decreases the amount of oxygen that's available for transport. So it's going to kind of that final outcome of that is going to be that reduced PaO2, CaO2 returning to that left side of the heart. Okay. Now let's talk about the shunt equation. So these are kind of that shunting and venous admixture are kind of common complications of a lot of different types of respiratory disorders. Like I was just mentioning, anybody that could have a consolidation or atelectasis or fluid in their alveoli are susceptible to having, severe or critical shunts. So we can calculate the amount of interpulmonary shunting using the classic shunt equation. Okay, so there is a million different ways that shunts can be calculated. Right now, we're going to focus on this one. So don't stress about other calculations that are out there. Let's focus on this one right now. Otherwise, you'll get super confused. So this is where that QS is that shunted cardiac output, and the QT is your total cardiac output. Okay. So in order to do this calculation, you need all of these different values, okay, in order to do this calculation. So this is on your worksheet twice, because this is a great way of demonstrating that you can do each of these individual calculations that are listed up here, right? You have to calculate all of these values. All of those values you have to calculate first in order to get your answer here. Okay, so sorry, I know that those questions on this last two questions on your worksheet are a lot of math. Okay, so just take your time, make sure you don't make silly calculation mistakes to get tripped up. You aren't going to calculate your shunt equation on the exam just because it's way too long, but you will have to calculate these types of values on your exam, which aren't that complicated. Okay. So clinically, the significance of pulmonary shunting is normally it can be anywhere up to 10%. So typically anything up to 10% is considered normal. If your shunt starts increasing, so 10 to 20 would indicate some sort of mild interpulmonary abnormality. If it's 20 to 30%, that's kind of significant. And if it's gets greater than 30%, then you're considering that life-threatening. All right. And like I said, I know I'm skipping through the calculations in the lecture, just because I feel like that is really hard to do in screencast. So I promise I will, at the synchronized session, during week 10, I will go through the calculations, and if you can't attend that one, at least be recorded. So I'll go through doing some of these calculations with you. But just wanted to make sure it didn't want it to get really confusing by trying to do it in screencast, because it's really set up well to do that. All right. So talking about hypoxia versus hypoxemia. So this is another important distinction I want you guys to be able to make. So hypoxemia is what we refer to when you have an abnormally low arterial oxygen tension. So your PaO2 values are low. Okay. So this is going to, if my PaO2 value is low, then based on my knowledge of the oxygen hemoglobin dissociation curve, my saturation of hemoglobin will be low, and my patient is going to try to compensate for this so that it doesn't reduce the total oxygen delivery to the tissues by increasing their cardiac output. So a lot of times you see patients that are hypoxemic, that have that low PaO2 with increased heart rates, increased blood pressures, because the body's going, whoa, 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 wait a second. We don't have a lot of oxygen going to our tissues. We need to increase our perfusion. So these are kind of the values. I need you to memorize these. Like, these are important values to memorize. You are going to need these values when it comes to ABG interpretation, which is your next module. So memorize these, write these down. It's definitely going to be on your chapter 7 worksheet in the next module. So definitely start committing those. Make your flashcards, start committing those to memories. You are going to use those values for interpreting ABGs from here to the end of your RT career. So you need to have those memorized. Hypoxia, on the other hand, means that you have inadequate oxygen at the tissue level. Okay, so this means that you don't have enough oxygen for that cellular metabolism that's happening at the tissue levels. If that happens, then you end up with anaerobic glycolysis, which produces a lot of dangerous fixed acids like lactic acid, okay, and can cause something called metabolic acidosis, which we will talk about in acid base next section, okay? So typically once you have those tissue oxygen issues, that your patient again is going to be that tachycardic, hypertensive. They might start experiencing peripheral vasoconstriction because the body goes, well, we don't have a lot of resources. We'd rather lose a finger or toe than lose a head or a heart. So we're going to constrict our peripheral vasculature so that all the blood is centralized. And then as the brain's not getting enough oxygen, the patient could be dizzy or confused. Okay, so again, we defined hypoxemia clearly by these values of these PaO2 levels. But hypoxia, because there's a lot that can happen between when that oxygen gets into the lungs and into the bloodstream and gets transported throughout the body, we classify different types of hypoxia. Okay, so, excuse me. You have a table in your book that talks about the different types of hypoxia. So you have hypoxic hypoxia or hypoxemic hypoxia. This is where you have inadequate oxygen at the tissue or at the tissue that's caused by low arterial oxygen tension. Okay, so this can happen because the patient's hypoventilating. So they're not getting enough ventilation in. So it can't diffuse across into the blood. It can happen because of high altitude. Remember that diffusion is, or partial pressures are going to be affected by barometric pressure. So as I increase in altitude, I'm going to have a decrease in my barometric pressure, which is going to ultimately decrease my partial pressure of oxygen in the alveoli, and thus decreasing my partial pressure of oxygen in the arteries. Okay. I can also have things like diffusion impairments. So anything that's that's Fick's equation again. So anything that's going to increase the tissue thickness of my AC membrane. So interstitial fibrosis, interstitial lung disease, anything that is going to decrease my alveolar surface area, like pulmonary edema or pneumonia or anything that might cause perfusion mismatching, like shunting or VQ mismatching. Any of those things that are going to cause that oxygen from not being able to get from the alveoli into the blood. Anemic hypoxia happens when diffusion's happening. Oxygen's getting from those alveoli into the bloodstream. That's all normal. But when it gets into the bloodstream, there's no hemoglobin for it to link up to and get transported with. So anemic hypoxia is any issue with the hemoglobin. So it can be from decreased hemoglobin concentration from anemia, which is literally I have low hemoglobin levels, or hemorrhaging for blood loss, or it can happen because of abnormal hemoglobin. So you can have abnormal hemoglobin where the carbon dioxide is combining with, or carbon monoxide is combining with the hemoglobin instead of, and then the oxygen can't. Or you can have methemoglobinemia. This is where the iron atoms, hemoglobin is made up a lot of iron, are oxidized into kind of a ferric state. And that makes it so that the body can't transport, can't transport, those hemoglobin cannot transport oxygen anymore then. So another one that this chapter doesn't specifically talk about with anemic hypoxia, but I just wanted to mention is sickle cell disease. one of your other chapters talked about sickle cell disease a little bit. I think it was diffusion. And this is a disorder. It's genetic, it's hereditary disorder, inherited kind of blood disorder. It actually is very much more prevalent in like African American communities. And it's kind of marked by these flawed hemoglobin. So, um, these hemoglobin, instead of being kind of those round donuts, they they form these kind of sickle or crescent shaped um, molecules, and they kind of stick together, and then they kind of block blood vessels and the movement of normal oxygen carrying blood. So sickle cell patients usually have a lot of oxygen transport issues. um, and typically, if you have sickle cell disease, you typically are pretty anemic, because these are kind of short lived or destroyed pretty quickly by the spleen. Um, and then it's also very painful. Like, these blockages cause, or that kind of occlusion or blocking of the blood flows can kind of cause a lot of pain for these patients. So, I just wanted to mention that disease because I feel like it gets touched on in a lot of different chapters, and I never know where to talk about it the most. But I decided hypoxia because that's a pretty prevalent thing that these patients experience. You might see them if you end up working in areas with a higher population, like I said, of unfortunately African Americans typically have a better more likelihood of carrying this disorder or having this disorder. So if you end up working in an area with a high African American population, you might encounter some of these types of patients. And they, like I said, have a lot of oxygenation issues due to this abnormal hemoglobin. Okay. Circulatory hypoxemia is, or sometimes called stagnant or hypoperfusion hypoxemia. So this is where blood flow to the tissues is inadequate. So oxygen then is inadequate, delivery is inadequate. So this could be slow or stagnant cooling of the peripheral blood, um, or it can also be caused by like anything that's going to cause decreased cardiac output, vascular insufficiency, some neuro controls that are going to tell the blood flow to the tissues to be kind of a little bit slower. Right. Histotoxic or toxic hypoxia. This is where your tissues have the inability to metabolize the oxygen. And probably the best example of that would be your cyanide poisoning. So it's always kind of surprising because like people are always like, well, who's running around getting poisoned by cyanide? When am I going to run into those types of patients? But you actually really have to watch for cyanide poisoning in your smoke inhalation patients. So your patients that have been in a fire, especially a fire that has melted plastics, that can a lot of times release cyanide and cause cyanide poisoning. So you should be kind of aware of that histotoxic hypoxia in your and anemic hypoxia because of the carbon monoxide in your smoke inhalation or fire victims. Okay. So cyanosis is a term that we use again for that blue-gray or purplish discoloration of the mucous membranes. So that happens when you have at least 5% reduced hemoglobin. Remember, cyanosis is kind of like a kind of a subjective type of symptom. It can be very difficult to interpret or detect depending on the patient's skin coloring. And then remember, each of us is going to be different. So to me, something, because I am practically see-through and you see every single one of my blue veins because I'm so pale, I might think that blue coloring on everybody seems normal because it's kind of normal on me. So I might not rate somebody's cyanosis because I'm so used to being pale very high, whereas somebody who's more normal complected or tan might see, me walking around with my pale blue, bluish tinged skin, might go, wow, she needs some oxygen. So, again, this is very susceptible to our interpretation. It's not necessarily clinically a very good marker to judge oxygenation status by. All right. All right, finally, let's talk about some carbon dioxide transport. So, um, carbon dioxide transport is really oxygen transport in reverse. So, we get oxygen from our lungs delivered to the tissues. We get carbon dioxide from our tissues and deliver it to the lungs. So, so at rest, metabolizing tissues consume approximately like 250 milliliters of oxygen and produce about 200 milliliters of carbon dioxide each minute. Okay, so that is every minute that is occurring in our body. So this is a worksheet question, but that goes into play with if you think about a cardiac arrest patient. Okay, so every minute I'm using 200 milliliters of oxygen in my at the tissue levels. If all of a sudden my carbon dioxide or my breathing stopped and I was no longer breathing at all, how long would the oxygen in my tissues last then? Okay, I'm trying to find it real quick in here. Talks about it in your book specifically. One second, sorry. Wow. I missed this. Oh, here. Yeah. So at 1 minute, the body, like I said, they're going to consume 250 milliliters of oxygen. So at 2 minutes, that's about 500. There's usually about a 1,000 milliliters of O2 of oxygen is going to then be consumed in 4 minutes. So death or cellular death or total oxygen consumption is going to be the total amount of oxygen in our tissues. That's how I want to say it. Total amount of oxygen that is in our tissues is about a liter, 1,000 milliliters. So if my heart stops right now, it's going to take about 4 minutes for me to use up that oxygen that's at my tissues at this moment. And then I'm going to start going through anaerobic metabolism and cellular death. So that's why it's so important that we start CPR quickly and start working on the patient and start getting the blood circulating and ventilated so fast, because after 4 minutes, you can start having permanent brain damage. So this is talked about in that clinical connection on page 279 in your book. Okay. So so the carbon, once the oxygen is dropped off of the tissues, it's used in metabolism. Carbon dioxide is that byproduct of it. That carbon dioxide is going to be transported from the tissues to the lungs in 6 different mechanisms. Okay, so 3 of those mechanisms are in the plasma and 3 are in the red blood cells. So the 3 ways we transport CO2 in the plasma is amnio compound. So this is carbon dioxide bound to protein. That's about 1%. 5% of it's bound to bicarbonate. And then the other another 5% is just dissolved as CO2 in the plasma. Okay. Then there's 3 ways we transport it in the red blood cells. And again, this is the most of it is transported this way. So there's 5% that's dissolved in the red blood cells as carbon dioxide. There's about 21% that's combined with hemoglobin. And then majority of it is 63% is bicarbonate that is, or CO2 that's dissolved in the red blood cells that gets converted to bicarbonate, so HCO3. So those are the 6 mechanisms and kind of the breakdown of how much gets transported which way. So CO2 is converted to HCO2 at the tissue sites, or CO3 at the tissue site. So most of the carbon dioxide produced at the tissue cells is carried as that bicarbonate. So so it gets kind of shifted into those red blood cells and converted from CO2 to HCO3. So then when it gets to the lungs, gets converted, that bicarbonate gets converted back to CO2 and is eliminated from the alveoli. Your book goes through all the chemistry of this. I did not want to talk about it in lecture because I did not want that to like bog you down, confuse you, make you cry. So again, this is just kind of a chart that breaks down how things get transported and the kind of the quantity of the CO2 that gets transported to the lungs. So we do have a carbon dioxide dissociation curve. So similar to the oxygen hemoglobin dissociation curve, the loading and unloading of carbon dioxide in the blood can be illustrated in the same kind of graphic form. Okay, so instead of having like an S-like shaped curve, the hemoglobin or the carbon dioxide curve is almost linear. So instead of being S-shaped, this is kind of a linear association. So that really just means that there's a more direct relationship between the partial pressure of CO2 in the blood and the amount of CO2 that is kind of contained in the blood. So that total content of CO2. So for kind of an example, an increase in partial pressure of carbon dioxide from 40 to 60 raises the CO2 content approximately about 5%. So kind of the same change on both sides. So those key CO2 changes have a greater effect on the total content of CO2 than the PO2 changes do on oxygen. There's that more direct relationship. Excuse me. Excuse me, I really got a frog in my throat now. The level of saturation of hemoglobin with oxygen is also affected by the carbon dioxide dissociation curve. So when hemoglobin is saturated with oxygen, there's less CO2 content for the given PCO2 than if the hemoglobin was, say 75% saturated. So this kind of effect, the fact that deoxygenated blood enhances or increases the affinity or the loading of CO2 is called the Haldane effect. So it works both ways. So deoxygenated blood enhances the loading of CO2. Oxygenated blood enhances the unloading of CO2. Okay. All right. So that is all for chapter 6. Remember, you have a worksheet that is due, as well as mind tap activities. And in this chapter, you will have an exam, which I will review with you at the synchronous session in week 11.